I work at Memorial Hospital. I have a pain clinic. I specialize more in the interventional side of procedures, but along with the practice comes treating every aspect of chronic pain. So I really want to talk to y'all today about drug abuse, especially prescription drug abuse in adolescents. We've always been taught that kids that fish and kids that play sport do not have a problem. They're the kids that grow up to be the pillars of our communities, the doctors and lawyers and such. That is not the case. Athletes abuse prescription drugs more than non-athletes. Prescription drug abuse leads to death. It is the largest, I consider the largest epidemic in our country right now. I'm going to go through these slides. We're going to talk about the epidemic of prescription drug abuse in America as a whole. We're going to look at statistics for young athletes, and we're also going to look at how we currently treat pain, musculoskeletal pain, and what are some of the new options as far as treatment that can reduce opioid abuse. So here's the epidemic of prescription drug abuse in America. Since 1999, you can see the number of deaths, this is per sum capita, increasing dramatically to 2007. I believe this is slowly increasing. We may have reached a plateau with some of the stricter regulations, tamper-proof medications, but Americans are more likely to die from prescription drug abuse than guns, illicit drugs, or any other accidental motor vehicle injuries, any other form of accidental death. Here's some statistics. Accidental death, falling, guns, traffic accidents, drug overdose by far surpasses the most common, what we think of as the most common causes of accidental death. Here's the adolescent population as a whole. Here's where they stand. We're looking at 8th graders, we're looking at 12th graders. You're going to look at prescription drugs, 1% falling off, less abused, 1%, Vicodin, OxyContin, then you get into some of your other prescriptions, Ritalin, medications for attention deficit disorder, cough medicine. You look at 12th graders, now you see the prescription drugs a little higher in the abuse realm. Vicodin's higher, your cough medicines are higher, Ritalin still stays about the same. So I believe this largely affects, as the adolescents are getting older, they're getting more involved in sports and so on, but this also reflects a trend in prescription drug abuse in America as a whole. Now, this is where adolescents stand in comparison to this is where adolescents who are athletes stand compared to adolescents in the general population. 12% of males that play sports abuse prescription opioids. That's almost a threefold increase. Go back to the slide. We're going to look at 12th graders here, 4.8%. Now you're looking at 12%. Females is almost a double incidence just because they play sports. This was a study done by the Journal of Child and Adolescent Drug Abuse 2014, so this is a recent study. Out of these athletes who are more at risk, this is intuitive, male, white football athletes. Football, it's in a more aggressive, competitive sport. More injuries, more doctor visits, and more treatment, more surgeries, more prescription drug use. And so now we're introducing a gateway for prescription drug abuse. And I want to look at that gateway and what do we do as doctors, as treating physicians, as therapists to recognize those that are at risk, and what are some alternative strategies. Now, what are some of the reasons? Of course, I'll discuss one of them, the competitiveness, but also there's a significant emphasis we put on athletes, even the youth athletes, to perform, to get that scholarship, to be the star athlete. I mean, football is the center of Friday nights in many of our communities, especially the smaller communities. That's good. This is a great thing. I'm not here to diminish competitive nature of sports. I played high school football and had my share of injuries, blown out ankles and tore tendons and muscles. I went through it all. I've had pain medications, I've had surgeries. I love it. It's great for our kids. I want my children to be competitive athletes, but we have to recognize and do a better job of preventing this risk factor for death. So we put a lot of stress on the athletes. Where do they get it from? Family members, relatives. A lot of that, I believe, is that our family wants our athletes to do better. They go to the doctors, let's treat this pain, let's get aggressive about getting them back in the game. And we have some stored up pain medications from mom's last gallbladder surgery and slip a little bit to help them go through therapy to get back in the game. So there's a lot of responsibility to go around, especially physicians. I'm not going to diminish that, but family and relatives do play a part. We're going to look at some other drugs of abuse. Anabolic steroids, high school athletes. Again, getting back to the stress we put on adolescent athletes to be competitive and be better. Anabolic steroids, growth hormones, we're pushing them to be better to get that scholarship so mom and daddy can be proud. Various reasons, but there's a lot of emphasis and stress put on athletes. So you're seeing more than just opioids. You're seeing steroids and other doping options and stimulants, and is a wide variety. So I'm not going to single out to prescription opioids, but I believe this does emphasize the stress that we put on young athletes. Again, going back to the human growth hormone, dramatic increase from, this was 11% of teens, grades 9 through 12 in a recent study, reported using human growth hormone, up dramatically from 5% in 2012. Again, it's another study just telling us that there's more emphasis to perform and be a better athlete. So what are the solutions? Recognize, okay, so how can we do this? Of course, this slide is the acute presentation. I mean, it's slumped over in the bathroom, fixed pupils, sluggishness, unresponsiveness, yada, yada, yada. Okay, this is something we'll recognize in the acute setting. I believe the athletes, the trainers, the coaches, the moms and dads are going to see that, but let's get to it before we get there, okay? What are some of the other risk factors that are leading to that point? When I was in anesthesiology residency, there's a huge emphasis on recognition of opioid abuse because anesthesiologists are around the strongest opioid medications known to man. The fentanyls, the sufentanils, a lot of stuff we're not familiar with, but are very powerful opioids. And so anesthesiology residents and anesthesiologists as a whole, OR nurses and people who have access to the medications are very high risk. And you know, the people that abuse the stronger stuff don't live long. You know, the sufentanils, the fentanyls, the tolerance and the dependence quickly escalates. Fortunately, there's a little bit of a time frame with the oral medications that aren't as strong, but in residency, there was a big emphasis. We watched videos on it. It was a big part of our training. That's because it is very hard to recognize. A lot of us have a misconception that this is going to be easy to recognize. It's always asking for pain medication, slumped over in the bathroom. No, is it very hard? Because the signs are subtle, and people who want this medication are very good at manipulation and doing whatever they can to mask this. So some of the things to look out for: a pattern of seeking medical attention for multiple injuries. Always that ankle sprain, always that show, whatever, minor injuries, but a pattern of continual going to the doctor, going to the training, needing to seek medical attention when the pathology does not go in line with the pain behavior or the symptoms. Longer than expected recovery time. And then the other risk factors. Anytime I see a patient in clinic who I'm evaluating their pain use, I want to look at the other risk factors. What is their pattern of alcohol abuse? What is their pattern of tobacco abuse? What is their personal history? What is their family history? So these are screening signs, and these are very strong patterns of indications that cannot be hid. The history is a history. All my patients that come in, I give them a screen questionnaire. What is their personal history? What is their family history? And we're always looking at medical records, because what they tell me is not different than what they tell their primary care doctor. So I'll put a lot of emphasis on what they tell other doctors than what they tell me. Urine drug screen, this is a kind of a question. At what point, maybe if you have a strong suspicion, maybe this is something that could be done at some form of screening, a physical, but I really think this should be reserved to a strong suspicion. You can get these smaller tests, cups that are cheap. In residency, we're always asked to pee in a cup for a drop of a hat. You find some resident has a bottle of morphine in their pocket, and probably because from a case they were doing early that day, we all had to pee in a cup. So we were very heavily screened, but again, it goes to risk factors. People in the situation are more likely or apt or exhibiting patterns or signs of misuse. This is a tool. When I was in my fellowship, a nurse that worked in our office, she had a son that liked to use marijuana. He was an athlete, and she was always jumping on him, and so she would bring these cups home, and she would have her son make him pee in the cup, and he was always getting in trouble. Okay, so how do we intervene? I believe this is just getting involved at the coach level, the trainer level. Anytime athlete has an injury, just go to the physician and just discuss, how are we going to treat the pain? What sort of medications are used? How long should the recovery take place? I always like when patients come to me and say, I do not want to be hooked on this medication. I do not want. And so we have a good dialogue, and these are very good questions up front. How are we going to address this? And then that gives me an opportunity to discuss my interventional options and what I can do. And that's a lot of times why patients come to me to circumvent just the prescription pain medications. And so it gives me an opportunity to talk about alternatives. But I really appreciate it when patients in journals, we have this upfront discussion. What are the alternatives? Of course, to intervene. I mean, if there's any pattern of abuse, they need help. They need counseling, professional. I just kind of want to make an emphasis about, a lot of times patients are always referred for pain specialists, but I believe this is for legitimate prescription use. Patients who've got no hips because they have traumatic injury, okay, they're probably going to be in pain for some various reason. And so that's kind of why I get involved. The pain is going to be difficult and long-term and hard to treat. So a legitimate prescription, for legitimate prescription drug use, but they may have a pattern of misuse. They're using more medications for pseudo-addiction. That is trying to treat their pain with more medications. It looks like abuse, but really it's pseudo-addiction. So it's just misusing it, but they have legitimate reasons. Abuse is illegitimate prescription. Always addiction specialists, when it's abuse, kind of my specialty when they have legitimate reasons, but a pattern of not using it or the pain's not controlled. So what are the alternatives? This is a very controversial topic, anti-inflammatory medications. I've got a lot of orthopedic surgeons here, and I'm sure they're going to be kind of looking at me closely. Don't give my patients anti-inflammatories. They just had a broken fracture, and it's going to have, and there's justification for that. But we're going to kind of just look at when is it appropriate, when it's not appropriate. Alternative pain medications, does it always have to be the Vicodin? Does it always have to be the Percocet? No, it doesn't. There's other less stronger, less likable form of pain medications. Long-acting local anesthetics, nerve blocks, these are kind of more up-and-coming solutions. And this is a graph just really illustrating how strong anti-inflammatory medications can be. Meloxicam, diclofenac, coming very close to equipotent as morphine. Of course, your opioids are, per milligram basis higher to get to your methadones, your fentanyls, your hydromorphones, but they can be strong. There's a lot of association that, it's just, whenever I hear a patient tell me, that Celebrex or that meloxicam is like taking water. I tell them, well, good, you have plenty of water. Take 2 glasses of water, call me in the morning. As far as likability, this is basically a lot of anecdotal evidence, surveys from drug addicts. They'll tell you they like the way the oxycodones, the hydromorphones feel. The less strong medications, the tramadol, the Suboxone, don't like it. But these are very strong painkillers, just don't have so much of euphoria. So it doesn't always have to be Vicodin or Percocet that's commonly prescribed. Now, how do we treat it compared to other countries? Well, this is from a Journal of American Academy of Orthopedics. You're looking at the Dutch population. 82% of the patients with ankle fractures in America were treated with opioids compared to 6% of the Dutch populations. The Dutch populations were given anti-inflammatory medication. So, again, it's a controversial subject. There's concern about fracture healing. I think we live in a very legalistic society, so there's a lot of concerns. But this isn't the only risk. So I'm going to talk about some other risks of anti-inflammatory medications, but there's a place for it. It should be used when appropriate. Hopefully y'all lunch is settled, because this is a GI ulcer that's bleeding, squirting out blood. This is a scope that they're trying to cauterize this GI bleed. Okay, I won't make you stare at that, but a pattern of long-term use of anti-inflammatory medications can slow down degrade the lining of the stomach. That's why Vioxx came out. That's why Celebrex came out. It is easier, more gentle on the stomach, but still strong as far as the analgesic effect. However, the problem with these we call enzyme-specific COX-2 selective inhibitors is there's a risk of cardiovascular risk, Vioxx. I mean, there's these lawyer commercials all want to attack the anti-inflammatory medications for increased risk of heart attacks and strokes, and doctors are very afraid to prescribe it because of the fallout with Vioxx. Vioxx was a different bird, different category, but it's another lecture. This is, again, some evidence that anti-inflammatory medications do reduce fracture healing, actually from the British Journal of Medicine, okay? So the Europeans do use it more, but even the British Journal of Medicine does recognize that that is prudent to limit their use with proven stress fractures. This is what a non-healed fracture looks like. You've got it pin plate, and it still looks pretty ugly. So it's an orthopedic's nightmare. What about the anti-inflammatory risk, the cardiovascular risk? Well, here's the FDA's recommendation, the black box warning on anti-inflammatory medications, increased risk of heart attack and strokes. This is a whole different lecture. You know, when should you use it? When should you not use it? But now we've got this big warning on anti-inflammatory medications, and everyone is concerned to use it. So this has led to the use of opioid medications. Let's just avoid all these risk factors. Let's just use the opioid medications and let the fallout lay where it is. But the problem is that's just the opioid death and opioid abuse. So what are some of the alternatives? Well, this is a very long-acting local anesthetic like lidocaine. It will last 48 hours. A lot of our surgeons, Dr. Cohen, and our orthopedic departments are making our pharmacy department heads stick their head in the ground because this is a very expensive drug. But it's a lot better than having the patient sit in the PACU, as I've seen as an anesthesiologist, puking and barfing and sedating them. And the patient's quality of hospital stay is a lot better when you don't load them up with opioid medications. They leave sooner, they get home sooner, so there's a lot of indirect cost savings I always try to emphasize to my pharmacy colleagues. Don't worry about the cost of the drug. You'll get it in the long term. You'll get more patient satisfaction. You will get them home more comfortable sooner and less nursing staff. And so there's a lot of indirects, but this is a very expensive drug right now, but it lasts a long time. It's kind of used right now as an infiltration around the incision, but it lasts a lot longer. But we do have this at our hospital, and we are very excited about its use. We've actually, Dr. Cohen has done a study with it looking at his knee replacements, and he's shown he can get his patients in rehab a lot sooner, and outcomes are better the sooner he can get them in rehab, and the therapists are happy because they're working with them a lot sooner. Okay, so this brings us to preemptive analgesia. Why do we want to get the pain under control soon? This is 2 slides. This is a patient who underwent a very bad fracture and is under surgery, and this is pain, nociceptive input. This is what happens afterwards, hypersensitive. The pain level is a lot harder to control because they just had a little bit of pain control. This is pre-surgical. This is during surgery, before surgery, during and after surgery. There's no hypersensitivity. The patient is a lot happier. The therapists are able to get to work with them a lot easier. They're more comfortable because they have no hypersensitivity. Okay, so what is hypersensitivity? Hyperalgesia. That's just more pain. So this is the patient who did not get good pain control before, during, and after surgery. They are a lot more sensitive to stimulus. Their pain levels go up real high. And this is a patient who is treated appropriately. The more they are able to tolerate stimulus a lot better before their pain starts to increase. This is another slide. Patients who have got preemptive pain control, whether there's a nerve block, a combination of pain medications before, during, and after surgery, their use of pain medications drops compared to the control in the patients who just got the normal IV pain medications during surgery and after surgery. So this is before surgery, during, and after. This is just during surgery. Okay, so what is a good preemptive analgesic strategy? This is an ultrasound machine. This is a nerve block, going in and numbing up the whole nerve. Let's say this patient had a wrist fracture. This anesthesiologist is going to go numb up that nerve, put some numbing medicine, some lidocaine around that nerve, and the patient can be up talking and having a conversation during the surgery. Not a lot of pain. The pain is controlled, so there's less postoperative hyperalgesia. This is an image of a nerve block. So this is a bundle of nerves. This is a needle going right next to that nerve and putting a little bit of numbing medication, lidocaine. Before we had ultrasound, you'd have to stick a patient in the neck, dig around, hope you don't get in a blood vessel, try to stick the needle in the nerve so the patient tell me, you're around my nerve, I can feel it in my fingers, okay, good, let me pull back a little bit. And so that also had the risk of vascular injury or puncturing the lung. And so it had a high risk complication, and so it wasn't a very well adopted strategy until the advent of ultrasound. And so you can see precisely what you're doing, put less medication, and a lot safer. Now this is a continuous nerve block. That's great, you did it. The medication lasts for about 12 hours, and the pain comes back and they rush to the ER. Dr. Cassio knows that. He gets very frustrated when that happens. But this is a continuous nerve catheter. You put the catheter around the nerve, and this is a pump that works for 48 hours. I've actually had a patient, I put it in for 10 days. I just kept refilling it, and this is for another chronic pain issue, but young girl. A lot of the problems, my experience with these initially was it would work great for a day or two and then it quit working, and you could never figure out why. And so recently had a young girl, admitted her in the hospital. I put in these nerve blocks. I had my physical therapist work on her arm, her extremity, while she was able to tolerate it. And I would make rounds on her, and every 2 days I'd have problems with the pump. It wasn't working. I noticed it was kind of wet around the neck. I just thought it was sweating, but as much as we did to seal that little catheter, it was dripping out. It was getting out. And so talked to some of our other anesthesiologists who work in, and we devised a strategy just to put some Dermabond around it. And we want to say, what would that do? After I put Dermabond, my previous experience, I replaced that catheter 3 times. After that, it lasted 10 days. So I feel very comfortable with using these as a very effective long-term strategy. The patients can go home on this. They can dial it up, dial it down. They can tune it up just the way they like it. They wear this nice little bag. They can put the little bottle of numbing medicine, and they just have a little catheter, and they go home and they go do activity as tolerated. So that's my presentation.